Ms. Kripke has been working with individuals and groups in periods of transition and change for over 15 years. She is currently a state co-coordinator for Postpartum Support International and is also a featured guest blogger for Postpartum Progress. We're honored to have Ms. Kripke with us today. Welcome, Kate.
Thanks. So I'm going to start just by saying I do a lot of teaching and training in our fairly small, I guess, compared to Denver community of Boulder. But it is such an honor to be here with all of you who have come from far to be here to learn more about these issues. It's always really moving to me when I get in a room with this many folks who are as committed and passionate about the care of moms and babies. So I just want to thank you. I know it's been a long day, kind of at the tail end. You're welcome to get up and stretch throughout my talk if you'd like, but really genuinely thank you for being here. So I'm going to spend the next, 45 minutes or so talking about the differences between what we're going to call normal postpartum adjustment and postpartum mood and anxiety disorders like postpartum depression. I want to kind of preface this talk by saying I think a lot of the information I'm going to give you today you're probably already doing, right? This probably is not going to be entirely new info for you, but I'm hopeful that if this is repetitive, you leave here with a better understanding of why it is so important that you're already doing what you're doing in the context of support, really of women across the gamut, women who are having a very normal postpartum experience all the way to women who are suffering from a more clinical mood and anxiety disorder. So a little bit about why we're talking about this today. Or not. A lot of time was spent looking at and deciding that maternal depression was one of the key areas that we needed to focus on in our state. And through all of the work that this grant, that folks involved with this grant looked at, it was determined that there were probably a lot of women across our state who were getting diagnosed with a mood disorder like postpartum depression who actually may not have postpartum depression, right? And some concerns about that, which is understandable. And so Krista asked me to talk about this mostly because we really want to make sure everyone has the information they need so that PPD is not underdiagnosed or overdiagnosed, yeah? A little bit of transparency here. When Krista asked me to give this talk, my initial reaction was, oh, that's easy. Yeah, I can talk about that, right? I know that stuff. And then I sat down to put a PowerPoint together, and I realized that this is actually an incredibly complicated topic. That those of us who are quote-unquote experts in the field of perinatal mental health don't always know the difference between what's considered normal and what's considered a mood disorder. Okay, so I have done my best to create as clear and as linear a PowerPoint as I can, but I say that with all of us knowing that this is not as easy to explain as we would like it to be. I am hoping that you walk out of here with three things. One is a greater understanding of the differences between, again, what we're going to consider normal postpartum adjustment, postpartum depression, and then all of the possibilities in between, right? There's a lot of gray area there. I'm hoping that you have a greater ability to assess distress, increases in levels of distress in moms as they move from maybe a normal adjustment to a more critical one. And I'm hoping that you leave here with more tools for support of really of all moms, right? But especially of those who you begin to observe the distress increasing. Bottom line, however, is that understanding the difference is confusing because it's confusing. This is my most educational slide up here, right? This is it. There is a very vast overlap between what we consider to be normal and what we consider to be pathological. Big overlap, lots of gray area. And this is why, right? Let's start with this. There are multiple words to describe something that we're all considering to be one issue, and I'm just going to read them. Postpartum depression, postpartum mood disorder, major depression with postpartum onset, postpartum distress, postnatal depression, maternal depression, perinatal depression, peripartum depression, and on, including baby blues, which we actually know is not the same thing, but all of these terms have been used to describe a similar issue for women, right? We don't even know what to call this. So, and this, by the way, is across the board, right? This is journal articles, this is professionals, these are physicians. We're all, for the most part, using different terms to call this period of distress. Why is the distinction important? Well, it is important, right? We want to make sure that women are not underdiagnosed. When mamas are underdiagnosed, significant distress in early motherhood is assumed to be normal, right? And then when women don't get the support they need, because it's assumed that all new moms suffer, right? And that's just not true. Motherhood is difficult, but it should not mean that a mama is suffering postpartum. Underdiagnosis further fuels the myth that some women can't tolerate motherhood, right? This is the Tom Cruise syndrome, right? We all remember that? And underdiagnosis, when moms are underdiagnosed, they're left to feeling as though they struggle because they're bad moms and not because of a real legitimate illness, yeah? There's also the problem of overdiagnosis. We don't need to always put moms on medication who are suffering and struggling. Sometimes that's incredibly important, as we heard from Karen Horst, but that's not always necessary. We also know that overdiagnosis further fuels this myth that the new mom should always be happy, right? If she's not happy, then she must have postpartum depression. We don't want that to continue. And lastly, and this was something that came up that Krista and I talked a little bit about before when she asked me to do this talk. Lastly, for some women, there can be this potential lifelong label, right, that they don't quote unquote deserve. I guess I will say in my practice, I find that when a mom is told she has postpartum depression, she's incredibly relieved. So this has not been my experience working with this population, but certainly something that we want to be mindful of. Why are they important? Why does it matter? Why are diagnoses important? Well, for one, accurate and important treatment and appropriate treatment planning often is based on diagnosis, right? We have best practice psychotherapies that might differ from diagnosis to diagnosis. Cognitive behavioral therapy, for instance, we know is really helpful for moms who are suffering from postpartum anxiety. Medicine treatment differs for diagnoses. And insurance reimbursement, right? Any mom who's going to use insurance, that insurance company is going to need a diagnosis to reimburse her. And then finally, collaboration between professionals, which I do a lot of in my community, and it is really helpful when we know that we're all talking about the same thing, yeah? But do they really matter? I don't know. I don't know if they matter. I think that what matters is that women who need support get support, yeah? And that when we are observing and listening and really paying attention, those moms who are distressed are going to get the kind of help they need. And when we spend too much time thinking about, is this postpartum depression, is it not, we often miss the boat. So I think there's a lot of value in understanding what's postpartum depression and not, but I also want us to pay attention to the fact that what we're looking for is whether or not a mom is significantly distressed. Let's talk for a few minutes about what we do know, because there's so much that we don't. We know about the baby blues. We know that the baby blues last a maximum of 3 weeks, so 2 to 3 weeks, and we know that baby blues are typically thought to be a very normal part of the postpartum adjustment. This is not postpartum depression. There's some myth out there. Sometimes the blues are what's used to describe a mom 3 or 4 months out who's having a hard time. Baby blues are not postpartum depression, totally normal, very expected. We do know that when this vulnerability lasts longer, there's probably something else going on. We know what's normal, right? What's typical. We know that every single mom is going to feel anxious and overwhelmed, isolated at times. We know that that is expected for every mom who delivers, for every mom in general, whether she's adopted a baby or given birth herself. However, when those symptoms happen more often than not, we want to keep our eye out and say there's probably something else going on here. I'm not going to read this, and I'm not going to get into the DSM-5 or DSM right here at all, except to say that we also are fairly clear on what is major depressive episodes or disorder for a mom, right? There's a lot of room for interpretation in the DSM, But we do know that, for instance, the DSM will say, well, here's 7 or 8 categories a mom needs to have, suffering from at least 4 of them to be diagnosed with a major depressive episode. Wendy Davis, who you all know, and a colleague wrote a great paper on the DSM-5 and perinatal mood disorders. Some of these things are directly from her paper. We know this is the first time, really, that the DSM has paid a little more attention to issues, not just depression, but also anxiety and panic, which is great for us. However, the DSM says that these issues, this significant distress, has to occur in the first 4 weeks after delivering a baby to be considered postpartum depression or major depressive episode with postpartum onset. 4 weeks, right? 4 weeks. Those of us in the field say 12 months, right? So 4 weeks is definitely not enough time. There's really no specific diagnostic criteria for these other issues that exist, including OCD, postpartum OCD, postpartum PTSD, or postpartum psychosis, right? There's no postpartum piece of that in the DSM. And we're really not being accurate when we diagnose every mom who suffers postpartum as having postpartum depression. We've heard a lot about that today, right? Moms are often struggling with anxiety, sometimes more than depression. So what do perinatal mental health experts know? Well, we know that postpartum mood and anxiety disorders can happen anytime in the first 12 months and that there's a range, right? We know that postpartum depression, postpartum anxiety, postpartum panic, postpartum PTSD, postpartum OCD, and postpartum psychosis are all real illnesses. When those of us in the field of mental health diagnose women with these issues, we're usually using the criteria from the DSM, right? Because we know that these issues are significant enough to create major stress and to really affect the functioning of a mom. We also know, by the way, I always use the percentage 20%. I know we've heard a lot of different stats in here today, and it, of course, ranges from 10% on, but I've always found this to feel the best of all the percentages out there. So I always say 1 in 5 moms. We know that about 1 in 5 moms will struggle postpartum with depression or anxiety, or a combination of the two. So what lies between? What lies between normal adjustment, which will include for good 85% of moms baby blues, if not more, and a postpartum mood or anxiety disorder? Well, there are 2 other diagnoses, really 1 other diagnosis. Karen Kleiman has retermed an adjustment disorder to, she calls it the postpartum stress syndrome, to really describe an adjustment disorder during the postpartum period. Excuse me. But we know that these moms who lie in between are struggling more than we would expect them to. So their distress is persistent, it lasts longer, it doesn't go away with reinsurance, but they don't meet the criteria for a major depressive episode. Excuse me. We don't talk about this much, right? We talk about normal and we talk about postpartum depression, but we don't talk about this stuff in between. In the DSM, there's specific wording, right, for an adjustment disorder. A psychological response to an identifiable stressor, having a baby, that results in the development of clinically significant emotional or behavioral symptoms. The symptoms must develop within 3 months of the onset of the stressor, indicated by either marked distress that is in excess of what we would expect. And on that, I want you to pay attention to the words here. I haven't coughed all day, right? Only when I'm up there. I want you to pay attention to the words here. There is so much room for interpretation, even in the DSM. So much room for interpretation, right? You indicated by marked distress, right? That is more than expected. I mean, according to who? Right? So there's a huge amount of room for interpretation here. But this is what the DSM says about adjustment disorder. Karen Kleiman, and I really, really, really like this description of postpartum stress syndrome, falls between the relatively minor baby blues and then the relatively extreme postpartum depression. It's marked by feelings of anxiety and self-doubt, coupled with a deep desire to be a perfect mother. Right? We see this happen all the time. This enormous expectation of being the perfect mother, perfect wife, in control at all times, combined with a very real feeling of inadequacy and helplessness, can create unbearable stress. This is it, right? This is this gray area that we're talking about. I can't quote the paper right now because I just don't have it on me, but there was a great piece of work. A bunch of folks were sort of trying to find a type of woman that was most likely to struggle postpartum. I always talk about this with my moms really carefully because we never want moms to think that they're to blame. But this paper really found that the women who are most likely to struggle are those who have high expectations of themselves, like to be in control, and are perfectionists, right? Not surprising. So you take that mom and then you put her into early motherhood, and there's a lot of distress there, right? Without appropriate support, this can often lead to postpartum depression. So the bulk of my talk today is about that support. And this is pretty self-explanatory too. Postpartum stress syndrome is most common in women where there is a significant external stress. Okay? Let's talk for a minute about this myth, this new motherhood myth, right? Birth. Let's all just imagine that this were true for a second. Birth is easy because women's bodies were made to deliver babies. Breastfeeding is easy because women's bodies were made to breastfeed, and women love to do it. All of us, we love it. There's all the lactation consultants would be out of a job, right? There is instant attachment and bonding when mom and baby meet for the first time. We now know that this is not true. This is not true. I can't tell you how many times a mom will think she must have postpartum depression because she didn't feel that instantaneously, and it's just not true. Mothering comes instinctively, and then there's its vision, right? The peaceful baby sleeping soundly in mom's arms after quiet and really is breastfeeding session. She's happy and relaxed. The sky is blue, the sun is shining, and visitors surround her giving gifts. What a lovely vision. Here it is, right? Newsweek in 2005 ran a story called The Myth of the Perfect Mother, and here she is looking beautiful and put together and happily doing a million things at once. What's the reality? New motherhood is considered by some, and this is real, this has been written about, as a life crisis, a psychic trauma, and an earthquake. These are real descriptions of motherhood by lots of people. Those of us who are mothers in the room can probably attest to this. Birth is rarely as moms expect it to be. Breastfeeding comes with challenges for almost every new mom. Almost every mom. There are massive role conflicts. Mother, worker, wife, daughter, I don't have that one on here. Major conflicts that cause initial discomfort and distress for everyone. The first year of parenthood is by far the hardest on a partnership in marriage. Gottman has written quite a bit about that. And then Dr. Rice talked a little bit about this morning, but sleep disturbance and lack of sexual interest is common in really every new mom, right? It gets complicated because these are also two symptoms of depression, so there is some overlap there, but we actually know that this is a very normal part of the postpartum experience. And that there are very normal feelings of ambivalence, guilt, doubt that come and go for every mom, right? Here she is. She's feeling a little crazed there. So we've got 4 scenarios here. We have the myth, right? New motherhood includes no distress and all happiness. Pure myth. We have the healthy, or what we might call normal, postpartum adjustment, which is that new motherhood includes some emotional vulnerability and periods of distress that are expected and that mom can tolerate. And by the way, my use of tolerate here is different than Tom Cruise's use of tolerate, okay? I'm not talking about whether or not she's likes it. I'm talking about truly her brain's ability to manage the stress. The third scenario is what we are now calling an adjustment disorder, or again, that term, the postpartum stress syndrome. Includes periods of distress that are expected. She has difficulty tolerating these, again, because of her brain chemistry, perhaps imbalance, high expectations, or an inadequate stress response, but she still maintains some level, some ability to function, okay? So her symptoms do not fit the criteria for a major depressive episode. And then we have a postpartum mood disorder like postpartum depression. And this mom is really struggling. Her symptoms are interfering with her ability to function, to care for her kiddo the way she wants to maintain relationships, to sleep, to work. There is a pretty big consequence of missing the imperative need for support early on here, right? And this is where I know that everyone in this room is already doing this, okay? But a normal adjustment can turn into a problematic one pretty quickly if she expects that her symptoms are abnormal, yeah? Shame and guilt can go deep for that mama, right? So we want to get in there, yes, during pregnancy, but not if during pregnancy, right during postpartum, so we can help that mom understand that that normal experience we just defined is actually, she's not a bad mom for feeling those things. But here's the problem. This is why this topic is so confusing, right? Distress and suffering are totally subjective. They're subjective terms. When a mom is experiencing any form of distress, we need to pay attention to that, whether or not we think what she's experiencing is normal or not, right? We may be watching a mom who's having, moments of anxiety and overwhelm, and oh, this is so hard, and I don't know if I like this, and what if I don't like breastfeeding, and I am having a hard time sleeping, and I don't like my partner, and all that stuff. And we may be sitting there thinking, yeah, well, that's normal, right? But if that mom is distressed by that, then we need to pay attention. So it doesn't matter what we think is normal. We need to pay attention to her reaction. The postpartum stress mom, this mom that we're talking about, this mom in the gray area, is not necessarily in crisis. Yeah? She is that mom who manages her life pretty well. She gets to work, she takes care of her baby. When we watch her with her baby, they're kind of sort of loving engagements. She may look put together, she's showered, she may be made up, has lots of friends, but when and she may not disclose the specifics of her distress, right? We see her and we say, how's it going? She says, oh, it's fine, right? And we're like, okay, she's fine. But when she closes the door at night, she crumbles. This is the mom, by the way, that I worry most about in my practice. I worry less about the mom who shuffles into my room, still wearing her pajamas, and all of her family is worried about her. I don't worry about her as much as I worry about this mom, because this mom is not going to reach out for help. Yeah? And this is the mom we're talking about. This is the mom in question. This subtle shift from normal to problematic is caused by lots of things, but three things that I see a lot happen in the work that I do. The first is unrealistic expectation and shame. That goes back to the first couple of slides, the myth, the reality, right? The second is what those of us in the mental health field call cognitive distortions. There's been a lot written about this. I have all my references are at the back, but two great pieces of work in a great book that you can read more about. But this is the perfectionist thinking, the catastrophic thought, the should statements, right? A mom who's typically, who engages a lot in this kind of thinking is going to have a really hard time with a normal postpartum adjustment. And then, of course, inadequate social support. Moms need villages. I don't care who you are, right? But there is something about our culture here where we expect to be able to do it all by ourselves. And the mom who does it by herself is much more likely to suffer, even if her experience starts initially being pretty normal. So what is the non-mental health provider's role in supporting the mental health of the postpartum mom? I have slides where I'm going to go into much more detail about these things. But the first is to provide the validation. Right, again, this is one of those slides where I know that you're already doing this stuff, yeah? But providing validation, helping set up realistic expectations. You want to encourage basic needs. We're going to talk more about these. I think almost every other speaker today has talked about basic needs. We're going to check for and support what, again, those of us in the mental health field will call biopsychosocial strengths. We don't really know what exactly causes a postpartum mood and anxiety disorder, but we consider it to be what we call a biopsychosocial issue, meaning that it is caused by disruptions in a mom's biology, her physical well-being, her psychology, her way of thinking, and her social system. So there's a lot of work that can be done in helping to support those three areas and assess for levels of distress and refer out to appropriate mental health support when necessary. We're going to talk about all of these. When you're assessing for distress, you want to look at three things: intensity, frequency, and duration of symptoms. A mom who is experiencing, again, what we're going to call normal, right, an expected postpartum experience, her symptoms or her anxiety, overwhelm, her symptoms are going to be less intense, they're going to be less frequent, and they're going to last for not as long. Yeah? When they start being more intense, more frequent, and last for longer, there's something else going on. Every diagnosis, whether it's the baby blues or a significant postpartum depression or something in between, there's a range of distress from mild to severe. Remember, we're not the ones who are qualifying that, right? They are. So her level of distress is going to be somewhere between mild to severe in any of these different scenarios. Last talk, Karen Horsted obviously talked about this as well, but typically milder symptoms are going to be alleviated with validation, support, reassurance. More moderate symptoms are usually going to need some mental health support, therapy, maybe groups, something a little more focused for her mental health. And the more severe symptoms definitely require mental health support and often will require medicine as well. So one of the things that we can do when we're assessing for the level of distress in a mom is to pay attention to whether or not the reassurance helps. Okay? When is mental health support necessary? Just what I said, right? When mom is improving with reassurance, when you've got that mom who you think is experiencing a normal experience and she's having a really hard time, and you give all the information about validating her experience and she still doesn't begin to feel well, we want to pay attention to that. When mom knows what she needs to feel well but she can't access it, right? That's the mom who knows she needs to sleep but she's got what I call monkey brain. She's up all night. She knows she needs to eat well but her anxiety is making it so that she has no appetite. That's the mom who knows that exercise, as we talked about earlier, or a yoga class would make her feel much better, but she can't get up off the couch. We want to pay attention to that. If mom is having scary thoughts about harm to herself or her baby, we've heard about postpartum OCD and postpartum psychosis today, but postpartum OCD is one of those things that we just don't want to mess around with, right? We want to make sure that mom gets the help that she needs. Someone said earlier, we don't worry about the baby in those instances because those mamas are going to do everything to take care of their baby, but scary thoughts of harm is excruciating for the mom. So we don't want to mess around with that. We want to get her the kind of help, mental health she needs. If you have concerns about mom-baby attachment, that's another reason to reach out for mental health support. These first few weeks, months are imperative for infant development. So we really want to make sure those moms who we're curious about get in there to get some additional support. When the distress is chronic and when mom can't access her basic needs. So these are all reasons, there are probably more that some of you out there can think of, but these are all reasons when it is time to refer out to mental health. And I'm going to talk about this a lot today, but when in doubt, reach out, right? If you are not a mental health provider or a medical provider, your job is not to diagnose, your job is to assess. And I think we forget that sometimes. There can be a lot of pressure to figure out, is this postpartum depression? You don't need to be the one to figure that out. So if you're in doubt and you don't know, refer out. And hopefully you have a lot of people who you can refer to in your community for mental health, and if not, Wendy has made it very clear that those of us from PSI can help you with that. Right? So in assessing for level of mom's distress, you want to do several things. You want to ask questions. You want to ask her questions. You want to ask how she's doing. You want to watch for signs, pay attention, and you're going to include others. I can't remember who it was who said this earlier, but I love this. We don't have to do this in isolation. We get to use the other people around us to help us figure out what's happening for the mamas who we work with. Your best tools for assessment and support are your awareness and your curiosity, okay? And really the best thing that you can do for your mom is watch it with her and help her identify distress when it occurs. This happens a lot where a mom gives birth and she has her family around and she's sort of in that perhaps euphoric stage of being a new mom, and she says she's doing great and we all assume she's fine, and then we back off. And that's part of the reason why I really don't like these, first 4 weeks or even first 3 month criteria, because it's often when everyone forgets about her that mom really starts to struggle. So we definitely want to stay by her side. So I mentioned earlier this idea of biopsychosocial strengths, and I think that if you can break a mom's wellness apart into those 3 areas, it can be really helpful to help her understand both where her strengths are and where her challenges are. These are some considerations for you and for the women who you work with. Is mom able to sleep when her baby sleeps? It's a big red flag if she can't. Is her appetite in check to appropriately nourish herself? Is she drinking plenty of water? Does mom understand effective breathing techniques? Sona spoke a lot about mindfulness today and not so much about breath, and I'm going to talk about breath in a little bit, but breath, a deep breath can change our body's physiological response to stress, right? So we want to make sure that our moms know how to breathe. Much easier to do when the baby's on the outside than the inside, but really important to help assess that for our moms. And when appropriate, is she engaging in healthy exercise? So we know that our thoughts affect the way we feel. So we want to listen for those shoulds and the high expectations of our moms. What are her beliefs about herself and motherhood? Okay, this is something that people don't talk about. But the second a mom looks at that baby for the first time and says, I am this baby's mom, all of her old stuff is going to come back. Whether she's been in therapy for years or not, whether her family of origin and her relationship with her mom is fabulous and strong or conflicted, it all comes back. And that can often begin that definition of herself as a mom. So we want to check in with that. Does she have access to healthy coping techniques? And if not, is she open to learning? Right, so this is when we talk about prevention, and that word is debated in this field. Can we really prevent postpartum depression? We do know that women who have access to coping strategies to deal with stress are less likely to struggle than those that don't. So we want to check in to see, does she have those already? And if not, is she willing to learn them? And then social considerations. Does she have a support network? Is her partner and family aware of how she's feeling? How many of you work with moms in the hospital before discharge? Is there anyone in here who does that? This is, I do a lot of training at our local hospital in Boulder for our nurses, and this is one of the things that I ask nurses to look out for, right? Who is with her? Who's in the room? Who's visiting her? What is your experience of that relationship? It's really telling of the kind of support that mom is going to have. Not always, but often. Is she able to request help and support when necessary? That's a big one. I have a question on my assessment form that asks, do you have difficulty asking for help? And almost everyone says yes, right? Moms who can ask for help and access it are less likely to have a hard time. So we want to check in about that. And then what do you notice about mom-baby attachment? So these, by the way, all of this is not diagnostic, right? This is all assessing. This is all assessment. When you are assessing for this gray zone, for this postpartum stress syndrome, there are a couple of really important questions to ask every single mom. And I mean every mom, right? I don't just mean the mom who doesn't seem to be having a normal experience, but every mom. The first is really easy. Are you concerned about the way you feel? Remember, I may not be concerned about her, but what I want to know is if she's concerned about the way she feels. She may say, no, this really sucks, and I can't wait till my baby's older, but, I know I'm going to be okay. And she may say, yes, I am scared this is never going to end. Or I'm scared that this means I'm a bad mom, or whatever else is going on for her. And then another question is, are you having any thoughts that are scaring you? Karen Kleiman recently wrote a great piece for Psychology Today, their web version. I'm not going to go through this, but these are different responses, and that's obviously a great question to ask any mom as well. When you are working with moms, again, whether you are assuming that she's having a normal experience or not, you want to watch for early signs of increased distress, right? Is she beginning to pull away from her community? This is that cycle. Mom is on concrete like this is really helpful. A lot of new moms will say, I don't have any community. And then when you do something like this, you'll realize that actually she ultimately will feel more supported. So Ariel Delphin, I think I'm saying her name right, wrote this book, When Baby Brings the Blues, and gave me permission to use this slide in my talk. I love this handout. I have it over 2 slides here. But it really in one column gives symptoms that are expected and not serious, and on the other column, symptoms that require support or are more serious. And I teach what I do call a postpartum prevention class at our hospital in Boulder. And I love giving this to my moms because they have something to actually look at when they get home, when they're home with their baby, to figure out whether or not what they're going through is normal or not. So a few things in summary. The baby blues is part of a normal experience. This is not pathological. This is not postpartum depression. Healthy and normal postpartum adjustment does include levels of distress and emotional vulnerability, which again, we consider to be tolerable, meaning a mom can withstand that. It's temporary, these symptoms go away with reassurance, they certainly go away with time as the baby gets a little bit older. Moms who have difficulty tolerating expected levels of distress may fall, not always, but may fall within the range of adjustment disorder or postpartum stress syndrome. And the difference between normal postpartum adjustment and an adjustment disorder or postpartum stress syndrome is subtle and depends on her interpretation of what's going on. The DSM is relatively clear for something like major depressive episode, although still includes a lot of room for interpretation. And it does not have adequate diagnostic criteria for postpartum mood and anxiety disorders. Any mom who is concerned about the way she feels needs support, again, regardless of how we assume she's doing. And your role, unless you're a medical professional, is to assess for distress. And when in doubt, refer out. That's all I have. I think I have a couple minutes. Are there any questions?